back to where this again is the insertion of the patellar tendon here. And let me see if this shows, what. So here's Hoffa's fat pad, if I'm not mistaken, up above here. But the stuff down below, and especially what looks like almost like a refractory angular thing down below. Let me pull it back, showing up right about there. What is that? Is that refractory, and what is it? What is it refractory of?
It looks like it could well be metalwork.
Now, when you say metalwork, would you say that that this is not a sonographic artifact that we're seeing? That line represents an actual piece of hardware.
If you run through it again for me.
I'm going to show you another one coming up.
Yeah, I suspect you're a bit deep there, but something is causing that appearance.
That is not fluid, and we are not seeing an echo shadowing or a refractory. So let me turn and go orthogonal with you if I can. Oh, this is another one. Let me see if I do any better job at finding this. Again, this darkness down below here is what I'm confused about. Isn't this the window that some people use for the ACL?
Yep.
Now you can see I'm coming off to the condylar side and pulling a little bit of the condyle in here. But what I want to do next is I want to slice this orthogonal or short axis, and you'll be able to see the patellar tendon at the top. And here we are here. Are you with me? This is patellar tendon. All right.
Yeah.
So what we'll see, or what I see, is that we'll pass over what I think to be a reflection here of the hardware, and then it drops down, and I see kind of
that is a small collection of fluid with some sort of dividing plane.
Do you see it go up and down there? Yeah. And that's that plane that I was talking about.
Yeah, that is not metalwork. I'm pretty sure it's not metalwork, but it may be. It has the look of something man-made, but I couldn't. At that angle, we can't say.
So you're telling me you think it's a piece of debris that fell from the surgeon's pocket, John? And
no.
I'm giving you a rough time.
No, that's all right. I'm seeing something. I'm seeing something like some sort of boundary. Is my best guess.
It does not look ectopic to you. It looks as though it could very well be some form of what they literally put in, and it's just a new window to something we don't understand.
It looks like if you think of it as a rectangle in long section, it looks like a rectangular fluid collection with a septation through it. If you play the clip, the longitudinal clip again.
That's this one here.
Yeah, there. So if you freeze it at about 26 seconds. Look
at you, man. That's that controller, airplane controller coming out.
25 seconds, yeah?
Okay, yeah. Yes.
Right. So what you've got there is immediately below the fat pad just there. So you've got, if you see that as two triangles.
Yes.
Yeah. The top triangle is definitely fluid.
And this is fluid within the joint.
Yeah. Well, behind. Yeah. Yeah.
Is this capsule here? Because is Hoffa or I don't know where.
Hoffa in theory is extrasynovial, but intracapsular.
Okay. Hang on, man, you're playing with me. Extrasynovial, but intracapsular, so that the knee capsule is sub patellar tendon in here.
The patellar tendon is the knee capsule at that point.
Okay.
In principle, it's the it's the retaining structure.
So what you're saying here is this to you would be intrasynovial, or at least this would be effusion within the joint.
Yes.
And this, you had said that it seems like it's some form of a septation, and it seems to you that you would say it certainly looks man-made, but you can't tell me whether this is fluid down to the bottom right here.
You can't be sure, because when you look, because if you had taken a slightly deeper picture, you might have got a clue, but because the boundary is so steep,
yes,
you can't be absolutely sure, because the sound won't pass through that very well. So in this plane, and because you can't see anything below it, because you haven't scanned with sufficient depth, you can't really comment on that. It could be, just in the same way as bone casts a shadow, so will a plane that is at a steep angle because of refraction.
I got you.
Yeah,
all right.
So everything below that line can be obscured when a line is a strong reflector and it is that steep. You've got a combination of refraction and, depending on what that is, acoustic shadowing. What makes it difficult to understand is what is happening here, because that is also a straight line, and that can be just a shadow.
Here.
No,
I didn't.
The vertical line. Yeah, that line is straight, and fluid collections don't generally have straight lines in them in that respect, not on their physical boundaries.
My mind thought this to be here metallic, and that this would be ring down.
It could be metallic, but I doubt it.
Okay.
Now, when you get but that is possible. Now, when you look at your long section, you see this very much looks much more like a septation. When you scan through the long in your short section, you get it looks very much more like a septation that is running through it. But again, that can be an artifactual appearance as you pass through. Yeah, if you go back to about 2019, yeah, there. Yeah, you see that plane there.
It's following. It's literally going down as I move the slice line, vertical and inferior. So,
yeah,
interesting.
But I think it's just going to be apart. It's certainly fluid above that line. What's below that line, I think, is conjecture.
John, you had said that your mind hungered for information at a deeper depth. As you take a look at this image, am I half as deep as you wanted to go, or would you go another 50% deeper?
I would go to the point where I was happy. If you go back to that image, the long image,
this one here.
Yeah, if you go into the long section image.
This one here.
Yeah, if you scan through that to about 20 seconds. Put it out to about 20 seconds. Where are we? No, that's not that. Where was it? Where? Yeah, there, about 25 seconds. Yeah, when I'm looking at that picture, what I want to see is what happens to the sound behind that line. Yeah.
So 50% lower, or whenever I see an interface or some form of echo below that is satisfactory. But until I see something, I'm not deep enough.
Yeah, well, it's what I sort of think. If I'm uncertain about what's going on in a place, then I sort of think I want that in the middle of the picture as a rule of thumb.
Okay.
And the reason is I want to see what happens to the signal underneath it. And on that, I'm pretty sure it's all shadowing underneath that. But it would be much clearer if there was a bit more depth. You could probably get away with 1 more centimeter or something like that, because then you would see those black lines just go straight down, way further than it could conceivably go.
See, what you're just sharing with me is the pearls that you're telling me that don't stop with what you see. You have to evaluate what happens to the sound below it, because it's important to identify what the characteristics are of the image by taking a look at how the computer processes the way sound returns.
Yeah.
Okay, I understand that. Let me see whether or not there's anything else I need your input on. I would be all the talk then, John. Are you seeing any dynamics right now on the screen?
Yep.
Do you,
Yep.
Here's another example. I don't know. Obviously, to me, this is hardware here. It comes at the edge of bone here, but
Yep.
I don't know what this is. Do you see what I'm showing you here? And as I go back and forth, anyway,
it looks it's difficult to say, and I just
I'm
don't know. I would guess perhaps some sort of ply key.
Okay,
Within,
but you'd say biological tissue somehow.
There are quite a lot of echoes in that fluid, and so there's some debris of some sort in there, perhaps.
In the fluid here.
That there, as you come across, the problem with a line like that is that because it brightens up further as you come back further there.
Yes.
That there could be creating that line there.
Oh, by physics that I don't understand.
By side lobe artifact.
Yeah, that's what I was talking about.
Yeah. I'm not sure, but you can only really see a side lobe artifact, which is the loops that go out in completely the wrong direction. The parts of the pulse that go off in completely the wrong direction. You can only really see them in fluid, but they are very confusing because they're so weak. They don't appear in your normal picture for all intents and purposes, your soft tissue picture. But when you have a fluid collection, you then see these replications of the strong reflectors that are off to the side, and so classically they're seen in the bladder. But that might be a very good example of one in the within that. What was that?
That was the orthogonal view. This is the one that we were looking at, and then this next one is 90 degrees on it. So we drop off the edge here.
Yes.
And I'm following the edge, but I'm trying to play right on the edge. Right there is where we're anyway. Yeah. I would like to facilitate you teaching me how to look at post-surgical knee plate patients after all of. There we go.
Yeah, let's have a look. But anyway, I got some of the other teachers from the UK that I've got some time for to sit in on it, and I got some criticism back from them, which is good. And the one thing they said was there was too many cases gone through too quickly. They thought that for the majority of people who were watching, they would get more out of me not rushing through the cases. So I'm going to take that on board, and I'm going to be much more selective about the number of cases, try and reduce them, but then allow people to soak in rather than me just going, I think this is this, and I think this is this. And so I'm going to have a run at that next time, and see how it goes, because it does feel a bit like an avalanche, you know.
Yes, but anyway. I think anytime you share casually, I think whatever raises to a level of an amazement for you is about 5 times the level of amazement for us out here. I think if you pick 2 or 3 cases and just simply went through, I would just like to hear your mind processing on this is why I think this is the case, because here, and I know this guy in the States who's as crazy as Trump, and he did not put the depth down to be able to see what the you know, that kind of stuff.
You were driving a 15 megahertz thing. You're doing pretty good for that day. that was I did not think you were driving a 15 megahertz thing. The picture wasn't all that bad at depth. Anyway, this is a patient walks through the door. I've got to share, don't I? Sorry, I'm looking at my screen and going, right. Well, have you got me?
Yep, I have it now.
Okay. This is the dorsal aspect, a lump on the dorsal aspect of the first MCP joint, so the thumb.
Yep.
Just a lump there. I thought it was going to be an odd osteophyte. It just just from looking from where they pointed, but it was this. Yeah.
Yeah, talk me through what you're thinking, because it looks cistular, if there's such a word like that.
But it tracks. Yeah. So it isn't what it looks like in one slice. As I go along, it's a tube. Yeah.
Yeah.
And you follow it back, and it's the dorsal branch of the radial artery. Yeah. And but see where it changed, where she's painful, and it changes shape. If I go back to there, it looks like that. And she's got a little aneurysm there, because when you look at it, pumping with blood, pulsing, and there, and filling like that. Yeah, you see?
Yes.
Just a little aneurysm. And that was like a theme that went through a lot of the cases I had this time, because there were lots of little vascular unusuals. And I'm going to pass over some of the stuff. Though I'm going to show this. Before I go on to the vascular ones. See the calcium? I'm going to put it on the other screen. So, right, can you see that calcification in supraspinatus?
Yes.
Yeah? As you go through, but what I really like the look of here is how it interacts with the capsular layer of the tendon. I'm hoping I'll get to the point. You see it streaking in long section all the way through.
Yes.
Yeah, but this layer is below, and I think I'm just trying to see it. I might actually be on the wrong case. Back in short axis, there. Do you see the capsular layer, the cable going across?
Yes.
So we're in short axis, but that's long axis on those fibers, or certainly more long axis.
That's really helpful.
Yeah.
There is a density above the cable that you're showing me right there. Is that a lesion, a fibrotic reactive lesion?
No, that's calcinosis. That's the calcium there.
Okay.
This is the main part of the tendon, with the biceps here.
Yes.
With anisotropy.
Yes.
So this is anisotropic, but because these fibers are going in a different direction, they're going underneath the calcium, they're still bright at that point.
That's very helpful.
And when we come back, and there's the long section, and there, do you see, you got tendinotic tendon there, you got capsular layer perhaps here, and this is the calcium, soft toothpaste-like calcium, tracking right from the insertion here, right back through to the muscular tendinous junction. So that was just a sweet one that turned up. I thought that was nice.
That's got to be. That has so many components, each of which is a slide, John.
Yeah. This is just silliness.
Oh, this is the spine again.
Yeah, this was a very slim lady, middle-aged lady, but you see her disc here is, if I play it, and you can just about, with the eye of faith, you can just about see the elements of the, this is the quadriquina here. Yes. And these are the filaments coming down, and there's the fluid. And this is the disc with its sort of pulpy centrum.
Yes. Man, every time I see those, I say, hey, John, you want to send that to me? Every time I see that, because I was talking to a doctor who came into, he was one of the people I saw. And I said, I've got this mentor that I talked to, this guru over in London, and he's actually using the window of the intervertebral disc. And now, and I said, yes.
Look at this.
Yes.
Do you see the soft?
I do, exactly do. And I see the long axis on the nerve fibers in the actual the spinal canal.
Yeah, this is the spinal canal here.
Yeah.
That's the fibers down there. But you see the patients, they are, I once had a young doctor turn up worried about a lump in her tummy. And she was shocked when I showed her that she was palpating around her belly button, her lumbar spine. But she wouldn't believe it. That's the lumbar spine.
Goodness.
That's 2 centimeters there. So it's at 1 centimeter.
John, and how hard are you pushing?
I'm just pushing down, just like you do when you scan. Just push down. The bowel just moves out the way, and as long as you're not closing off the aorta, as long as you're just to one side of the aorta, that's what you see. In someone who is essentially slim, that's what you see there.
We don't have a lot of those over here, John.
It's age does it too.
Yes, that's fascinating.
That's just a bit of fun. It doesn't really have a lot of clinical value, I don't think.
Oh, what it does have is it tells you what the adjacent possible is when you take a look at other things. I mean, it allows your mind.
And you don't get confused when you see things.
Right.
Biceps. This was, I don't think this is necessarily, sorry, I've opened that in completely the wrong form. We'll go here. And yeah, so I've got a couple of interesting things to show on biceps. This is a typical difficult scan. Yeah. So this is an old boy with a knackered shoulder and having lived a good hard life. So the sound is not going through him very nicely. Down at 4 centimeters. This is the biceps here.
Hold on one second. First off, what is knackered? He has a knackered shoulder.
Yeah, there are lots of things wrong with it.
Okay. And so he has, what you're saying is that he's been through the rough parts of life and has had injuries and accidents and that kind of stuff. And what we have is a poorly, it's an unhealthy tissue that you're trying to look through.
Yes.
All and that is knackered. Yeah.
Knackered is a knacker's yard. In Old English is where you the place you sell horses to when they are finished their useful life.
Oh.
So that's where they would deal with horses.
Knackered yard. All right.
Yeah. So when a horse was knackered and needed putting down, it went to the knacker's yard where they turned it into glue back in the day.
That's right. Okay.
Tired.
What did you go tired?
We use the term for tired as well. So if you're knackered,
if you're really knackered, you're super tired.
Yeah.
All right.
Yeah. So you've got the biceps here, and the point I was trying to make to people is that when you get a rubbish picture, that the fact that the biceps is not resting against the greater tube, because that's the greater tuberosity, where if you're looking for pec major insertion.
Yes.
It's lower part of the greater tuberosity, but the long head of biceps should touch it as it comes up. And so if it doesn't, then that tells you almost immediately that it's not ruptured, but it is dislocated. And that's what you should be looking for. And you see all this stuff, it comes right over to the side and it disappears. And there you see it come together. So that's what I followed down. There you see the humeral head.
Wow.
And
you were down at the insertion of the pec major, and the insertion of the pec major, you say, goes into a rim that will follow up to the greater tuberosity.
Yes. And that's why when I teach shoulder, I always teach people to, when they find their lovely starting point at the short axis of long-headed biceps, instead of just going straight up, I always go, I just always follow it down, because sometimes you can't make out what's going on. But if you follow it down and look for the where pec major distorts the shape of the humeral shaft at the very bottom of the greater tuberosity, that gives you a lovely landmark. You see how the musculotendinous junction develops. And that tells you, and it being in the right place, because that is one of the reliable things in ultrasound, that muscular tendinous junction of the long-headed biceps always occurs at the level of the pec major. So if you're struggling to work out what's happened to biceps because it's just a mess higher up, those are your clues. Whether the biceps is pulled away from the greater tuberosity, or that groove that the pec major inserts into, but also when the muscular tendinous junction occurs a little bit further down. And at that point, you know that you've got, it's either lengthened because it's bowstringed out, or by dislocating, or that it's ruptured. And so even if you see it up in the groove, you can pretty much guess that it's likely to be ruptured and reattached in the groove, which is something you see often.
From the very beginning, John, I start my scans of the long head of the biceps at the pecs, and so but what you already, I mean, you stated it like we all know that that's the greater tuberosity. I didn't, so I'm going to actually have to pull out my anatomy book and go, whoa, from the greater tuberosity all the way down to where the pec inserts. It will allow me to be able to at least, mentally become more spatially oriented if I think about that as I elevator scan up to the top of the humerus. Interesting.
I don't think anyone refers to it as, but they're continuous. That bony outline of the groove. You see how the lesser tuberosity falls away. The greater tuberosity, that groove carries on all the way down to where pec major comes in.
Yeah.
And it's just a nice sort of, it's an elegant way of just tying all those bits of information together.
Yeah.
So if I go on, there's quite a lot to show that I think you'll be interested in. This is, let me see. Yeah, this you might have seen because I put this one out on Twitter, just a short clip of it. So yeah, I think you saw that. This is biceps, distal biceps.
John, you were beyond my brain when you put that out on Twitter. I tried to follow that, so I'm gonna need to have you go through that more specifically, because tell me it like you're teaching your student, because that's what I am.
Okay. So you come along, you're here, you're in the muscle belly of biceps.
Yes.
Yeah. So, and this scar-like thing, like the scar on Harry Potter's head, is epineuritis that becomes the long head of biceps or the biceps tendon there. Yeah. And short axis.
The distal biceps tendon.
Yeah. Distal biceps tendon.
I'm with you.
Yeah. And then it dives down here. Yeah, so it
yes.
drops down and gets harder to see.
Yes.
Yeah. And then it inserts here. It flattens out and inserts onto the radial tuberosity there.
Yes.
So you're in short axis, which is my favorite way to look at this. And you go from there to there. Right, and then I think I've got a better picture further on. So that's, oh no, oh yes, that's the tendinosis there. You see, so it's sorry, I'm mixing up the cases. This isn't the one I put up on there, but do you see how the tendon looks abnormal here?
Yes, yes.
It's and then you come down a little bit further. It inserts there. Do you see how it's spread? Do you get the idea, the sense that this blob here? It flattens out like in England we sometimes say like strawberry jam landing on a runway.
Okay. So this is part of that aponeurosa that goes out to the soft tissue.
No. This is the tendon. It inserts like a hand. It comes down as basically two tendons.
Yes.
Next to get side by side, so you often can't see them separate. And then as it inserts, it goes from roundish, two round blobs to they flatten out, and then they insert as quite a broad insert.
Your musket analogy up at the supraspinatus.
Yes, but it's there, and I think I've got a better clip of that. But this is the tendinosis.
Yes. And you just went long axis on it, correct? You went
from short there.
Yes. Yeah.
I just turn the probe round to be long. You can see it's markedly thickened.
Man,
So
I wish one of your sono hacks has you doing that, and I watch that periodically to try to see if I can't pull that in.
Yeah. It's right. Where is my distal biceps bursa? Right. Yeah, I think this might be the offending article. This might be the other one that I thought was. I think it was a slightly easier scan. Yeah. So you see the tendon coming down here.
Yes.
And then it comes, but here the bursa is dilated underneath it.
Ah,
so
I can see
just
that.
Before the insertion. And then there it is. And you see again that broad sort of crescent-like insertional zone.
Why are you looking at these? The person is coming in with what you think to be a possible tear of the distal biceps tendon, or why are you, is it just part of your scan?
No, this in this case, they came in for a shoulder scan. But as they were telling me, and patients often tell you, you know, they've got a sore shoulder, torn, and they've got pain down the arm. And that's a normal thing for them to say. But this guy specifically mentioned he had problems unscrewing things.
Oh, okay.
And so as I was scanning biceps, I just went down and had a quick look at the, you know, you turn the elbow out and you can quickly look. So that and I saw this fluid around the tendon itself. Did not look terribly tendinotic, but it's but you can just see fluid underneath it. So the bursa, the distal biceps bursa, is thickened.
Fabulous.
So yeah, so that's, but it's a nice thing to, you know, because it explains some of his pain. If they can do what they like to the shoulder, but that's not going to change what happens down there.
Yeah. I was totally with you. I've looked at that a number of times on Twitter, and there are times when you post things and I just say to myself, crud, one day I'll know how to orient myself to that. And I must have just gone over distal biceps tendon thinking that it was the long head of the biceps, and I just couldn't see it. But when you tell me it, now I can see you going long axis and all that. So
I sometimes wonder, some of the stuff I show is a bit obscure. But
I think it's headier than what most of these other people are sharing, and I feel bad. So I'm so intimidated. I just don't say anything.
No, it'd be really good if you don't understand anything. Go if you dare go and ask. You can check first with me that it's not a silly quote, but go and ask the question.
Okay.
You know, because it's good, because that I don't want to. I'm a little bit reserved, and I don't want to kind of say too much and think, but I can answer questions about it. But I don't really want to put on a lot of this is this and this is this and this is how to do that. But I'll happily answer questions about it.
All right.
It's just scarring, post trauma. I think I've shown you that one before. There was something. Did I show you the venous pseudoaneurysm?
No.
Okay. It was just a weird one. And pseudoaneurysms for, do you know what a pseudoaneurysm is in an artery? Okay. You see them a lot in radiology, or regularly in radiology, where the cardiologists have put a catheter into the groin, and they go into the artery and they push sort of various things to look at the heart. So they go up there, but they use an entry point there. And sometimes when they take it out, if they don't press hard enough there, the blood escapes out of it and forms a little sac. And that's called a pseudoaneurysm.
Oh.
Yeah.
Okay.
And they can be quite dangerous, and they're quite problematic. But they're in arteries. You rarely get them in veins. So a little sort of sac and it's not an aneurysm, because an aneurysm is when the tube gets bigger going along. This is like a little sac that runs off to the side, like a diverticulum, but of a blood vessel. And this was and I saw this little cyst in the sole of the foot. This is right on where you walk on the metatarsal heads, and I thought, is that a ganglion? And then I pushed down on it and it collapsed. And I thought, well, it must be some sort of little collection of fluid. And then I just saw that it occasionally just filled up with blood.
Wow.
Venous blood.
Now, how come you say venous blood? How can you be so sure? Because it doesn't have an intima, or you don't see the heart beating when you push down on it a little bit?
Yeah. Yes, and I've seen a lot of arterial pseudoaneurysms, and they pump away. They're like little, with the color on it, like the yin yang sign, because the water, the blood's flowing. Like this. Whereas this just fills up and then empties.
Wow.
Yeah.
Was this being symptomatic, or did you just find something?
Well, it was a little bit tender. But you see, you see there with the grayscale on, I'm just pushing the stuff in and out of it.
Yeah.
So if you go there, but that's where you have to. Oh, and a bit longer. Yes, you can just see the blood just going in and out as I'm pushing it in and out. So that took a little bit of figuring out, because I thought it was just a collection. I was pushing it from one place to another, but I couldn't find the other place. And then I realized it was actually coming off the little blood vessel. So
it's incredible.
And staying on the theme, and we'll call it a day in a moment. But
I'm not rushed. I know you need to get to bed.
No, I need to go and talk to Christine. But I've seen this a few times. You get these this is the ulnar artery, and it goes round in a little circle. Yeah, so it does like a little barrel roll as it's going through the palm.
Huh.
And I think actually I saw two of those in short succession. I'm not sure. I thought the other one was on this list, but literally saw two of them on almost consecutive days. And I asked one of my vascular friends, and he said that occasionally they don't know. They're not specifically. Yeah, this is it. I don't think they're described in the literature, but he's seen them and associates it with using heavy tools like the road diggers or this guy used a chainsaw a lot. And you see how it just
yeah, I did, like a little corkscrew, right at the. Yeah. Why would it do that?
Well, presumably it's an injury, and then there's been a little bit of scarring, and the vessel has bent round it. That's usually why that sort of thing happens. But yeah, it was a little kind of.
There it is.
Yeah, a little snap. Well,
a little snap roll.
A snap roll, yeah. It just was a quick snap roll.
Yeah.